Well, good morning. Dr. Sil here, junior doctor from Australia, and today we're doing a talk about electroconvulsive therapy. There are three major treatments in mental health that have incredibly good evidence for how safe and effective they are. The first is lithium for bipolar disorder. The second is clozapine for psychotic illnesses. And the third is ECT, and that's why we're here. So ECT gets a bad rap. There is a lot of stigma around it. The classic is The One Who Flew Over the Cuckoo's Nest, where Jack Nicholson, the main character, was punished by getting ECT without any anesthetic. But ECT is not a punishment. It is a treatment. It is effective. It does not cause brain damage. It causes brain healing and neurogenesis, and it's really an incredibly powerful tool. If I ever had a treatment-resistant depression, and in some cases, even if I didn't have a treatment-resistant depression, I would want ECT for me. So before you click away, a couple of hot points. It is evidence-based. It is safe for people of almost all ages, as long as they can tolerate anesthetics. It includes people who are pregnant, and the speed of recovery is much quicker than that of a lot of medicines. So that's why it's important. Now, in this talk, what are we going to talk about? I'll talk a bit about an introduction. I'll talk about the physiology and the mechanism of action. We'll talk about the indications and the contraindications when people can't have ECT. We'll talk about medical issues and anesthetic issues and potential side effects. I'll talk about the practical things at the end and what the patient would experience, like the step-by-step process of going through the actual process of receiving ECT. And this will be kind of spoken at a level of a junior doctor, senior medical student, but I'll try and make it so that anyone can watch this video and at least learn a bunch of useful things. All right, let's begin. So what is ECT? Well, it's essentially a small current of electricity that is passed between two electrodes on someone's scalp. And as the electricity goes from one electrode to the other, it's going to depolarize the neurons between the electrodes, and that will induce a seizure. Now, I agree that it's a bit mind-boggling to think that a seizure can actually be therapeutic, that it can help. Like, it sounds so archaic, but what they found historically is that people who were psychotic and had epilepsy would actually have relief in their psychosis after epilepsy. So there was thinking that it would be useful in some mental illnesses. And after they've done studies and found the evidence, it's actually most effective in treatment-resistant depression. It's also very, very effective in treatment-resistant mania and in some psychotic illnesses. A quick rundown on the evidence. There have been many sham ECT randomized controlled trials. So that means people go in, they get split into two groups at random, and people get ECT and get put under anesthetic, and people don't get ECT but still get put under anesthetic, and everyone tells them that they got ECT, and there is a significant difference in the effectiveness of treatment. It is extremely well supported by almost all psychiatric networks and organizations. So, for example, in Australia, the Royal Australian and New Zealand College of Psychiatrists has position statements saying how important ECT is. And America and the UK and France, etc., they all have their support for it. And even the World Federation of Societies and Biological Psychiatry support it. So it's very well supported by the by the healthcare body. The thing to remember is that the evidence to support that it works is based off people who are treatment resistant. So it's people who have failed, many other treatments that would normally be used. It still has a positive effect. So imagine how effective it is if it was first line. Now, everyone's different. Everyone gets different responses. So to talk about a bit about the predictors of what would result in a more positive response, the predictors are a shorter duration of illness, a lower severity of illness, psychotic features, because psychosis responds very well to it. So depression can come with or without psychotic features. People who have psychomotor agitation, where they're very antsy, or psychomotor slowing or retardation, where they move very slowly, and you see them drink a cup of tea and it takes a long, long time. Interestingly, the sex, age, and previous episodes does not predict how well one will respond to ECT. So let's talk a bit about the physiology. So, during an ECT, there's not only the electrodes that provide the small current of electricity, but there's also electrodes that monitor your brain waves, and this is called an electroencephalogram or an EEG. It's kind of like the ECG if you ever had one on your heart or done one. And so it's essentially two electrodes. There are two frontal and two mastoid, and it takes the potential difference between those electrodes and then produces that on a graph, and this is what it looks like. So here are some EEG patterns that are common physiologically. So when someone is aroused or relaxed or sleepy or asleep, and in deep sleep, they have different patterns that are produced in these EEGs. Now, EEGs are not a amazingly specific, accurate way of measuring neuronal activity, right? It's getting the potential current difference between 2 points that are about, 15, 20 centimeters away from one another. And between those 2 points, there are hundreds of millions of neurons. But when you look at the average kind of fluctuation in activity, it can tell you very important things, such as their state: aroused, relaxed, sleepy, asleep, or if they're having a seizure. So let's look at some of the EEG patterns you see when we are doing ECT. So the first thing that happens is a small electric pulse is delivered. And these pulses can be brief or ultra brief, and we can talk about that a bit later. What happens is you get different phases that induce a seizure. Now, if you've ever seen a seizure, what it kind of looks like is someone will space out. They usually have a prodrome for a couple of seconds where they know something weird is about to go down. Then they get a tonic phase where their arms just kind of stiffen up, and then they'll have a clonic phase where they'll start having a rhythmic convulsion. But anyway, that tonic phase looks like this. You get these hypersynchronous polyspikes where it's up, down, up, down, up, down, down, down. That's like this. And then you get a clonic phase where you have these rounded kind of waves with spikes between them. Now, and then phase 4, you get this kind of suppressive phase. Look, in the actual room, just to let you know, the person is on anesthetic and muscle relaxant, so they don't remember, they're unconscious, and they don't shake like crazy. There can be some minor kind of shaking, and that's totally dependent on the amount of muscle relaxant used, but there's not these kind of horrific stuff that you see in like The One Who Flew Over the Cuckoo's Nest. Now, this postictal suppression or suppressive phase can last for a minute to a minute and a half, and then usually after the seizure, one is pretty drowsy for about half an hour. It's called the postictal phase. Now let's talk a little bit about the mechanism of action. So when you have a seizure that's been electrically induced, it actually leads to a hypermetabolic state in the brain. So you have a doubling of blood flow. And with that blood flow, there's doubling of oxygenation and doubling of glucose uptake. So it's a very busy time. With this extra blood flow, there's actually a breakdown of this rigid blood-brain barrier, but it's only transient. But it's important to note because if someone's on a medicine, more of it will get into the neurons if someone has a seizure. And so, for example, lithium, you can have a lower dose than you would normally need if you're doing ECTs. Now, obviously, it's pretty easy to imagine that when you're having a seizure, it's a sympathetic kind of explosion. Your heart rate goes up, your blood pressure spikes, and you have adrenaline release. But then after the seizure, you get a parasympathetic release, a slowing of the heart rate, bradycardia, and a lowering of the blood pressure. Important to note there's an anaesthetist during all this period, so it's being monitored, and if there's any issues in heart rate or blood pressure, the anaesthetists have a whole arsenal of different drugs that they can use to help. Now, in terms of the actual physiological changes at a microscopic level, it's not fully understood exactly what's happening between neurons at the synaptic level. But there's different theories. There's the neurochemical hypothesis, which talks about the altered neurochemistry that happens similarly to how antidepressants work, which is affecting the serotonin, the dopaminergic, the noradrenaline systems. The neuroendocrine hypothesis, and there's an immunological hypothesis around neurogenesis and synaptogenesis between neurons and different pathways. But what we do see is very important brain structures, like the dorsolateral prefrontal cortex, which is a kind of orchestrator of the brain, and it is very underactive in people who have depression. After they get ECT, the activities come back up, and activity in the amygdala, which is very high in depression, comes back down. So there is changes that are lasting after ECT in these important brain areas. So in terms of the indications, ECT is useful for major depressive disorders, atypical psychoses, bipolar, schizophrenia, catatonia. It can be useful for delirium and agitation and aggression in dementia. It's also used to reduce suicide, and it's also an effective adjunct to medication because it increases their potency to get through that blood-brain barrier. I find it really sad when someone has tried medications for years before considering ECT, and then they try ECT and have the positive response, and they had years of their life where their brain is essentially getting brain damage from their illness. Like, it should not be considered as a treatment of last resort, is the point I'm trying to make. So what isn't well treated by ECT? What's not indicated? Well, essentially things like neuroses and anxiety disorders. That doesn't have a positive response or a significantly positive response to ECT. And there are reasons why you wouldn't get ECT. Because it increases your intracranial pressure, you wouldn't get it if you have high increased intracranial pressure. Also, if you're at risk, like the anesthetic risk is quite serious. So if someone has a really bad heart because they've had lots of heart attacks, or they're very frail and elderly, so they wouldn't get a general anesthetic, or they have a very complex airway, maybe they have a tracheostomy that gets plugged or something, like these are contraindications. Some of them are relative and depend on the anaesthetist. And sometimes you have to weigh up the negative of not treating the mental illness versus the negative of the anesthetic. But the good news is many pacemakers and cardiac defibrillators aren't actually affected by ECT, but you still need a cardiologist opinion because they need to do an assessment and make sure that the exact device they have is safe. And if it's a implanted defibrillator, then they can turn that off before the ECT. You do want to optimize the physical health of people getting ECT because essentially different states can affect seizure thresholds and different medications can affect seizure thresholds. So the way ECT works is they determine your seizure threshold and then they give you on the next treatment, because obviously I haven't said it yet, sorry, but it requires more than one treatment. You usually get up to 14 spaced out maybe 2 or 3 times a week. But anyway, yeah, if you're dehydrated, if your electrolytes are abnormal, like a hyponatremia or hyperkalemia, these change your seizure thresholds. If you're on medications like anticonvulsants or benzodiazepines, which is what's used to treat seizures, obviously that makes it much harder to give you a seizure, so we try and avoid them or reduce them as much as safely possible. But I was asked the other day, is epilepsy a contraindication in ECT? And the answer is no, because when you get a seizure, your brain has a neuroprotective response that raises your seizure threshold every time. So often you need a bit more of a stimulus every single time you get ECT. Maybe not every single time, but every couple of times. So if you have epilepsy and you get seizures, actually doing it therapeutically will mean you get less seizures because the seizure threshold is raised, so it's less likely to be triggered. False teeth can be removed, but seizures do cause tightening of the muscles, even if there is muscle relaxant on board. So usually we use a bite guard as well, just to protect that. Now, some of the adverse effects of doing ECT. So look, nothing in medicine is risk-free. And when you hear the risks about ECT, you need to think about comparing those risks to the risks of not doing ECT. So people who are saying, I'm going to have memory problems. Well, guess what? When you are depressed, you're not remembering much. Your brain isn't optimized. Your executive function does get affected by that. But anyway, let's list off some of the risks. So the biggest thing in ECT is the risk of the anesthetic, which is the same risk in any surgery, but there's a mortality rate of between 1 in 10,000 to 1 in 80,000 treatments. So, you have an anaesthetist there to do a full review before you get the anesthetic. So, and there's 2 to 4 doctors in the room usually when you're getting ECT. So the safety is absolutely optimized. There's a risk of headaches, probably because of that increased intracranial pressure. You can get tongue or teeth injuries, but that's reduced with the bite guard. You can get sore muscles after the first session because you've had a seizure, and that can hurt that can make your muscles feel tight. And in maybe 10% of courses, you can get a bit of confusion after the first ECT, but that usually gets better as you get more ECT. In animal studies and autopsy studies and in brain imaging, there's no brain damage found macroscopically at all. There's no shrinking of any brain areas because of ECT. If anything, it causes neurogenesis. ECT does not cause brain damage, is the point I'm trying to make. It can affect memory. Okay, so some changes is some people have problems with autobiographical memory, verbal fluency, so how easy it is to speak, and kind of anterograde amnesia, so they can lose memories of the time they got ECT and maybe a week after it. And they might also use retrograde. They might have some episodic retrograde amnesia where they lose memory of memories in the past. So there was one patient, for example, who couldn't remember their daughter's wedding. But that is more common that is reduced with a right unilateral approach. So there's different approaches for ECT. That's bifrontal, bitemporal, right unilateral. And we always start with the least invasive, which is the unilateral side, and we use the lowest amount of stimulus for an effective seizure. And so that reduces the risk of that happening. So everything is optimized. And if you're wondering why do we use right unilateral placement, well, it's because most people are left hemisphere dominant. So if you did it on the left hemisphere, they would have problems with language, which is, the dominant side of your brain is where your Broca's area is, the part of the brain that speaks. So if you did ECT on the dominant side, you would have problems with speaking. But some people are actually right brain dominant. So you find that sometimes you do have to do a left unilateral. All right, let's talk about the patient experience and the actual practical flow of what someone goes through when they get ECT. So you'll have a consent done with a psychiatrist, and then your first case will be a seizure threshold treatment. So it's usually not that therapeutic. It's really to find out what the goal of the treatment is to find out what amount of what's the lowest amount of stimulus you need to induce a good quality seizure. So in terms of the experience of the patient, they're probably sitting on a couch, they have the consent done. That could have been done days before. You can refuse at any time, you can decline at any time, you can leave at any time, unless it's an involuntary treatment, but that's for a different video. And also, if you're getting ECT, you want to be nil by mouth from midnight. You can take your important medicines with sips of water hours before. Check with your doctor, but you want to avoid all the benzos, anti-epileptic drugs, and insulin because you're not eating. Also, hot tip: make sure you wee before you start your ECT because you don't want to kind of be on the table and find out you need to wee. You'll get placed into a hospital gown, you'll go into a bed, you might get a cannula in and an anaesthetist, and then you get wheeled into an operating theatre, so big, sterile looking room. There'll be an anaesthetist and an anaesthetic nurse probably to your left, and there'll be the psychiatry team to the right, and there'll be wards people moving the bed around. The anaesthetist will put a cannula into one of your veins. They'll talk to you, they'll have a little chat and a little review, and they'll put some medicine into your vein that'll chill you out and make you feel like you had a really good sleep. I mean, I've had patients who didn't really respond to ECT, but they loved the sleep that they got from it because they hadn't slept well for so long. So, that's a nice side of it. When you're under anesthetic, the anaesthetist will be in charge of your airway and oxygenating you and making sure you're breathing. You'll be under a muscle relaxant, so it's actually the anesthetic who controls your breathing, just like every other surgery, by the way. And then while you're awake, this is important. Sorry, I forgot this. While you're awake, you'll have EEG electrodes placed on your forehead and your behind your ears in the mastoid area, and you'll have one on your right clavicle. These aren't giving electricity. These are just monitoring electrodes, okay? And you'll also have on your chest some ECG electrodes to monitor your heart rhythm throughout. So that can be a bit daunting when you're getting things stuck on you or whatever, but they're just monitoring stickers. Then when you're unconscious, you'll have the two electrodes that deliver the stimulus while you're unconscious, and your muscles will be relaxed. So we get a real tracing of the EEG kind of activity. Then they deliver the stimulus, and then they watch the different spikes that we talked about before, just here, and they look and they wait for it to kind of suppress, and then the anesthetic wears off, and you'll be monitored with an anaesthetist. And then when you start breathing again, waking up, you'll be left in recovery with a full team of nursing staff and doctors, seconds away, and they'll be measuring your vitals, and if there's any issues, you get a review straight away. And then, after you need about 2 hours of monitoring, you can't drive home. You need someone to drive you home, but you can catch a bus or a taxi or something. And that's it. That's your treatment for the day. It can be done as an outpatient or an inpatient. So most of the time it's started whilst you're an inpatient, but it can also be done as an outpatient. So this is a personalized therapy. It's not one size fits all. We don't just give everyone the same stimulus. You get your first session, which is a titration session, and then on the next sessions, you're given the stimulus that has been personalized for you. So the three types of ECT are right unilateral, bifrontal, and bitemporal. You're unconscious, so if you're a patient, you won't realize this. But if you're a junior doctor or a reg or whatever, you'll be doing this. So the bitemporal. Well, let's start with right unilateral because that's the most common. That can be either ultra brief or brief. Ultra brief is 0.3 milliseconds, so that's the speed at which the stimulus is kind of pulsed at, or it can be brief, which is 1 millisecond. The electrodes are placed between the canthus, the ear, the halfway point, 2.5 centimeters above that. So around here, I can't see it on myself, obviously, but around there, that's the first one. And that'll be a flat electrode, and then there'll be a rounded electrode, which is in the sagittal plane and just 2.5 centimeters to the right towards the ear, and that's the vertex. Bitemporal, you leave the right temporal one, and then instead of at the vertex, you just go to the left temporal. And bifrontal, you bring it up essentially right above the lateral canthus of the eye, 2.5 centimeters, right around there. The effectiveness goes up from unilateral to bifrontal to bitemporal, but so do the side effects. So the more effective, the more the side effects. So we always start with the least kind of intrusive one, which is the right unilateral. If there's severe dysphagia, by the way, if they're slurring their speech afterwards, it's probably because they're right side dominant, which is only 10% of people-ish, maybe 15% of people are right-sided dominant, which means the next time you'll go on the left side. All right, that was a big video, guys. That's all the main points I wanted to talk about with ECT. There's probably a lot more we can talk about, and if there's any questions, put them in the comments below and I'll answer them. That's basically it. I hope you guys have an awesome day. Leave your comments down below. Like the video if you want to support my channel, and I'll see you in the next video. All right, bye for now.